goodie bag, but they're kind of always spaced out on the tables. And it is beautiful out, so we're gonna wrap it up here. So, all right, side effects of chemo. The side effects could be temporary and or they could be permanent, okay? So some things that we're gonna talk about, bone marrow suppression. Another name for bone marrow suppression is myelosuppression. Myelosuppression, it's on the next slide, so don't worry. Alopecia, which we'll talk about. Mucositis of the mouth, and so I have a picture of here where sometimes chemo can cause really a lot of mouth sores, like canker sores times 100. And so we have to talk about how to avoid pain with that and infection, since our mouth is very dirty, okay? Skin changes, and then not only physical, but emotional. We have to think about being diagnosed with cancer can cause anxiety, can cause stress, not only for the patient, but their family. That's what I'm going through right now with my father-in-law. We don't have a plan still, don't know when his surgery is. It's causing some stress, for sure. Okay, so here's bone marrow suppression, myelosuppression. And so what chemo does is, it of course kills the cancer cells, but it goes to the bone marrow and can affect the three main things that the bone marrow makes. The bone marrow makes white blood cells, it makes platelets, and it makes red blood cells. So the bone marrow makes white blood cells, platelets, and red blood cells. So when they're on chemo and that bone marrow is suppressed, all three are suppressed. Platelets are low, white blood cells are low, and their red blood cells are low, okay? So, with their white blood cells being low, what does it put them at risk for? Infection, yeah. If their platelets are low, what does it put them at risk for? Bleeding, yeah. And then red blood cells being low puts them at risk for anemia. Okay? So, we have to talk about how to prevent those complications from happening. Infection. We educate our patients who are on chemo to monitor their temperature. If their temperature gets above 100.4, that can be very life-threatening, where they can go into sepsis. Sepsis is a systemic infection in the body. When they don't have the white blood cells, the fighters, to fight off that infection, it can lead to death. Okay? So this is what I was referring to with reverse isolation, neutropenic precautions. When their white blood cell count gets extremely low, they're put into neutropenic precautions or reverse isolation. So we are protecting the patient from us. Strict hand washing, always. No sick visitors or personnel in the room. If you feel like you got a sniffle, you think it's allergies, but you're not sure, you're not taking care of someone whose white blood cell count is 1.7. Private room when possible. No freshness, so no fresh fruit, no fresh vegetables, no flowers. Because all of the fresh things can have bacteria and viruses and fungus. I think I told you guys a story about my uncle who had liver and lung cancer, was out in his garden, like rototilling springtime, and there was a fungus that was in the soil. He inhaled and he ended up he got septic very quickly. His white blood cell count was very low and he ended up passing away. So no freshness when their white blood cell count is low. limiting visitation. Okay. Also another thing is, if we can, vitals machines should be designated for that patient. So the vitals machine should be in the room with that patient. Okay? And we're gonna monitor their temperature every 4 hours while they're in the hospital. So designated vitals machines, and every 4 hours while they're in the hospital. So that's for infection, but we have to think about bleeding precautions because chemo can drop the platelet count. So electric shaver, no rectal temps, no IM injections. We have to think about bleeding for sure. And then when it comes to mouth care, we want to prevent an infection. And once again, the mouth is a dirty area. So we want to do oral hygiene. And if we're gonna delegate that to our nursing assistants or nurse techs, want to make sure that they don't skip it. Even if the patient's super tired, doesn't want to do brushing their teeth, we can't skip PO hygiene, oral hygiene. Okay? So mouth care is a must. Because not only does it decrease the risk of infection, but it helps with those mouth sores. So they can have mucositis, which is mouth sores. Here's a picture. Extremely painful, you guys. I mentioned canker sores times 100. So frequent mouth assessment and oral hygiene. You can't skip that oral hygiene. And we want to talk to the patient about what to avoid as far as what could cause more pain. So spicy foods, acidic foods, like dry, rough foods like toast. Mouthwashes that contain alcohol. That of course is gonna cause more pain. So they wanna avoid that. Brushing their teeth and tongue at least every 8 hours and after they eat. Because when they have open sores and their white blood cell count is low, then that's prime time for infection. Okay? We can give them ice chips to kind of help with the pain too. But you can see how this could lead to malnutrition, right? They don't want to eat because they have these sores in their mouth. Another reason why they may not want to eat is chemo can cause nausea and vomiting. It can be while they're receiving chemo. It can be after they receive chemo. Okay? Not all chemo causes nausea and vomiting, but a lot do cause that. So what we do to help with this is we actually give them medications to help decrease that nausea. Ondansetron is a medication that we can give IV, Zofran, to help. It's best when given before the nausea occurs. So sometimes they'll give the patient ondansetron before they start chemo. Okay? Another side effect, now not all chemo, but some chemo can cause alopecia, hair loss. Hair loss is temporary, it's not permanent. A she has very long, thick hair, and she lost her hair during treatment, and when it grew back, it was very like curly, different texture. Yeah, yeah. So this, of course, the physical component, but alopecia, hair loss, is psychosocial as well, for men and women. And so we want to help the patient pre-plan if they know they're gonna lose their hair. There's a couple different things they can do to pre-plan. Some people choose to shave their head before they start treatment so that they don't see their hair falling out. And if they choose to wear a wig, then there are certain organizations, one is called Look Good, Feel Better, where they will fit them with a wig that's kind of flattering. They'll do a makeover type of thing for the patient. Another option is this, a cooling cap, which I have a picture of. So cooling caps help to decrease hair loss. And so they wear it during the chemo, as the chemo is being infused. And it's cold, so it kind of freezes the hair so that it doesn't, chemo doesn't affect it. Okay? The thing with cooling caps is they're expensive. Yeah. Sometimes covered by insurance, right? No, yours was not. Okay.
Now they have the machines.
Mm-hmm.
When I had mine, it was like separate caps.
Okay.
And you had to keep them in your freezer. And then like the day of chemo, you had to like pack your cooler, pack them on dry ice.
Really?
Like I think it was 3 hours before your chemo started, you had to get them on dry ice.
Oh, wow. Okay.
And they were cold.
Yeah.
Like I actually got like frostbite on my forehead.
Oh, really? Wow. And that was, so technology has advanced since not that long ago, so now they have the machine that kind of gives us cold.
Like they had the machine when I had mine, but the cancer center, like, cause I was at one cancer center, and like, they don't like us to bring the machine in because of X, Y, or Z, whatever reason it was.
Okay.
And I think now they have the machine available, but it's only available like certain days, so they only have one machine, so if
Yeah.
they have 2 patients that wanna use it and they're on the same chemo,
Yeah.
one of them just doesn't get it.
Yeah, yeah. So it can be very costly, and so sometimes patients, speaking of socioeconomic, may not be able to afford the cooling cap, but it does help to decrease that hair loss. Okay?
It's really weird when you get the hair loss too, your follicles actually hurt.
Your follicles hurt? Your
Like I
hair-
could tell like where I was gonna shed, I'm like, oh.
Really?
Because like it felt like, you know how when you wear your hair up in a ponytail
Yeah.
for like 2 days or whatever, and you're like,
Yeah.
oh, my hair hurts.
Yeah.
That's how it felt.
Oh, interesting. Okay. Something I didn't know. Thank you for sharing. Any questions, you guys, so far? Okay. Another thing that happens with chemo is some patients get something called chemo brain, and this can be very frustrating for the patient, where they have reduced ability to concentrate. They're kind of like in a fog. Memory loss, difficulty learning new things, and there's so many things that are being thrown at them with their diagnosis and treatment and whatnot that can be really frustrating. My husband's aunt, who passed away quite a few years ago now, but thinking about her and what she went through, this was the most frustrating thing for her. Not the alopecia, not being diagnosed with cancer, but the chemo brain, having this reduced ability to concentrate. So what we want to do is educate them to discourage things that also hinder their cognitive level. So alcohol, recreational drug use, activities that increase risk for head injury, so playing football, okay? So just talking to them and being supportive about this. Chemotherapy induced peripheral neuropathy. So peripheral neuropathy, loss of sensory perception of motor function of peripheral nerves associated with exposure to certain anti-cancer drugs. Ugh. So they may have this side effect, peripheral neuropathy. So we want to educate them, very similar to if a patient with diabetes had peripheral neuropathy, about water temperature, foot care, and so on. occupational therapist may help with that, with properly fitting shoes and things like that. Okay? Alright, pop quiz. The nurse is observing the assisted personnel provide care to a client who is neutropenic. Which action by the AP requires the nurse to intervene? Oh, I'm sorry, yes. Oh, B? That was already. I thought you had a question too, I'm sorry. Good job. It is B. So, using the unit's mobile blood pressure machine to assess the client's vitals, right? They should have their designated own vitals machine. Okay? All the other ones is what we want them to do, right? So using alcohol-based hand foam before touching the client, cleaning the client's bathroom with a disinfectant, performing a bed bath because the patient's too tired to get in the shower. So still washing them up, we don't wanna skip that, okay? Good job, thank you. All right, so we talked radiation, we talked chemo, now let's talk surgery. So there's lots of different reasons why the patient may have surgery. It could be prophylactic, so I mentioned if they have that genetic counseling and they test positive for the specific genes, then they may choose to have that tissue removed prophylactically, okay? Surgery could be for diagnostic purposes, so biopsy in particular, where they will remove just part of the tissue and they will look at it under a microscope, and that's how that staging system kind of comes into play, okay? Curative, to remove all of the cancerous tissue. Debulking removes part of the tumor, but they can't remove all of the tumor because of how interwebbed it is and how it may be hard to get to. So they'll remove part of it to alleviate symptoms. This is more of like palliative treatment. Palliative, here it is. So symptom relief and improving quality of life. And then reconstructive. So after that tissue is removed, then they can have reconstructive surgery. So I have some pictures here. So this guy, I don't know if you guys heard about this guy. He was a patient at Royal Oak. He had, it was called synovial sarcoma. And so he had cancer of his soft tissue in his face, okay? And so prior to his reconstructive surgery, which this is reconstructive surgery, right after the cancer was removed, he looked like you could see his skull on this side of his face and his bone, his facial bones. You could see his eye socket. He didn't have skin on the side of his face, okay? And so he went through multiple reconstructive surgeries and they were unsuccessful. And so he went to Royal Oklahoma and he met with Dr. Chiasset, who I worked with. He's an incredible plastic surgeon. He was the medical director of the microsurgery center and I was the nursing director. He's incredible. And so he actually did reconstructive surgery, and this was part of the after reconstructive surgery. So he's growing the skin on this side by putting grafts in and things like that. And then he went on to have more reconstructive surgery after this. But even with this, you can see how happy this patient is. And these are his parents. He was a hockey player, and so he was able to kind of get back out and play hockey. So even though you may think, wow, this is really extreme, this is much better, and he feels much better self-image wise after this reconstructive surgery. Okay?
Were they able to remove all the cancer?
Yes, they were able to remove all the cancer, but what was left was like, I hate to say this, but have you guys seen Terminator, where it was like just metal, or Two-Face from Batman? That's how it was. And I hate, yeah, just to kind of give you a picture of what he looked like prior to this. Okay? And he went on to help like raise money, because Dr. Chaya said not only does reconstructive surgery like this, but he also does cleft palate repairs for little ones like in third world countries. So he raises money to fly them here, do reconstructive surgery, pretty much when no one else will touch a patient to kind of move past whatever they have going on. Dr. Trident says like, all right, I'll do this. He's awesome. Another kind of, I just threw this picture in. You guys don't have to know the details of this, but it's just kind of interesting as well. This is to remove skin cancer. It's called the Mohs procedure, where, so here's the cancer right here, where it's circled. And what they do with the Mohs procedure is they'll take horizontal layers of the tissue and they'll put it under a microscope. And if they still see cancerous cells, because they look different, right? We've looked at that compared to normal cells, then they'll remove more tissue and more tissue. And so for this guy, here's post-op what it looks like. So even though it looks like a tiny little mole that looks different, underneath how deep that cancer went. And then this guy has multiple sutures, and then over time, it heals by bottom up, just as wounds heal. And now, post-op follow-up care, he doesn't have hardly a scar. Okay? Yes.
Actually, my father had that procedure for his ear too, and it was like right here. He ended up losing
Half a little bit of his ear. Wow. Okay. Yeah, this guy was right before the ear, but I could see how you could lose some of it. Okay. Uh-huh. Deep. Oh, wow. Yeah. So, just kind of once again, talking about the ABCDE of skin changes and how important it is. So, with surgery, there's always risks, right? We talked about immobility. So, what other risks happen after surgery, post-operatively? What do you think? Infection, yeah. Okay, what else? What about with immobility, what can happen? Muscle atrophy, skin integrity issues, what else? Blood clot. Okay, so what are we gonna do to prevent a blood clot? Anticoagulant, what else? SCDs or TEDOs, compression, what else? Get them up, yeah, get them up and moving, good. Okay, so infection, blood clot, pneumonia. So how can we prevent pneumonia from happening? Incentive spirometer and move them, yeah. My mom has an incentive spirometer at home, and my son last night was just asking me how to use it. I don't know why, but how do you use an incentive spirometer? Suck in like a straw, good, to enhance, this is what I told my son, to expand your lungs, good. Okay, a child from a nurse, and a nurse for a grandmother too, lots of questions. All right, survivorship. So this is the last kind of topic with cancer. So cancer is now being considered a chronic disease due to advances in technology and medications. Like for instance, that cooling cap wasn't a thing 15 years ago. And you may think 15 years is a long time, but really when it comes to healthcare, it's not that long ago, okay? When someone was diagnosed with cancer in like the 1990s, it was pretty much like a death sentence. There were a couple different treatments. Blue chemo was one of them, which is very, very harsh. And so now there's different radiation. Proton beam radiation is even more specific. There's different treatments for the complications. So now it's considered a chronic illness. But survivors have unique physical and psychosocial needs. Because of treatment, there can be long-term effects. So they need to follow up with their oncologist, their main provider on a routine basis. They may need routine imaging, blood work. They may need EKG done. depending on the type of chemo and radiation, they could have infertility after. They can have a risk of secondary malignancy from occurring. And so on top of, once again, the physical and following up and getting diagnostic tests to make sure that they hasn't spread and it hasn't gotten worse, we need to talk to them about psychosocial too. So I talked pre-planning if they're going to be losing their hair. There's lots of different support groups, spiritual care resources. Cancer centers have a wealth of information. Okay? So, some last minute questions here. The nurse is providing teaching to a client with breast cancer who will undergo chemotherapy and alopecia is expected from medication. Which statement made by the client indicates a need for further teaching? B. Good. Because why? It's not permanent. Excellent. It's temporary. Okay? The home health care nurse is visiting a client who has undergone a mastectomy. The nurse determines that the client demonstrates the greatest adjustment to the loss of the breast if which behavior is noted?
A.
Okay. Okay. I hear A, I hear B, I hear D. All the above. Not an option, I know. This is like a very classic NCLEX question, where it's like, all of these I could see being right, but what is the most right? Okay?
A because you're.
It is A. It is A. Yeah, because you're looking at it. The patient has acknowledged and is beginning to cope. Yes. Okay? You guys good with that one? You'll probably see that one again. Okay?